thank you for accepting this abstract for presentation. This is a hopefully a nice clinical accompaniment to Ben Durham's presentation before me. Sorry. There we go. My disclosures. So the background, as we've heard in the last hour, is that there's certainly broad responsiveness has been seen to MEK inhibition across MAP2K1 mutations, and even in our in the initial report from our COBE study, we saw broad responsiveness regardless of MAP2K1 mutation. Although I think we're learning that the real spectrum of response is not not entirely known yet. And as Ben mentioned, we've become particularly interested in the E102, I103 deletion and the sort of related class 3 disorders. So these variants have shown variable response to MEK inhibition. I think in the lab, there's instances of resistance, whether it's diminished binding of allosteric agents. That's one possibility. And then there's a scant literature of single cases. I think there's a colon cancer case that was resistant to MEK inhibition. Then there's varying, I think there's 2 or 3 case reports of response in one case, resistance in another. And I think there's a recent additional case where a patient didn't respond to COBE, but responded to trametinib one way or the other. But I've been, the more I sort of consult and hear about cases sort of in different places, I've just, the experience has been that these mutations lead to pretty aggressive disease. And so we've developed an interest in this particular manifestation. So in this study, we wanted to characterize the clinical features of patients with histiocytic neoplasms harboring this specific group of mutations, to look at their sites of disease, see if there's any pattern, describe what specific variants were detected, and then to characterize their response to treatment. And as I typically do, sort of looking at conventional treatments on the one hand, which is to say steroids, chemotherapy, immune suppression, and then targeted therapy. And then as a highlighted component, I want to show our experience with ulixertinib, which is an ERK inhibitor. So this is a retrospective study with cases mainly from MSK and then contributed from other centers. These are patients with confirmed ECD, LCH, or mixed disease, class 3 mutations by next generation sequencing. Their sites of disease, sort of as we have standard, we capture them in a standard fashion. Best response by imaging, complete, partial, stable, or progressive disease. Then subsequent to a response, was there progression, as a dichotomous, yes or no? And then our 5 patients treated with the ERK inhibitor. So we've studied 19 patients so far with this group of mutations. And just to point out a few things, about half had some kind of neurologic involvement, which is fairly high. I'm not sure that can really be accounted for by enrichment, given my specialty at this at this time anymore. 100% had bone involvement, and then 90% were multi-system. So this is looking at it that way, a bit of a more aggressive manifestation just in terms of sites of disease. These were the variants that we noted, sort of theme and variation on the 102, 103 deletion, and then just some kind of specifics, because I think these questions could come up. None of these cases had any other MAP kinase pathway. They didn't have a second mutation. A couple patients had some other somatic mutations identified in their sequencing, the ones that I listed here, BCOR and others. One patient had a likely pathogenic germline mutation. So this was happening in association with some kind of inherited syndrome. And then one patient, the testing was without match to germline. So there was like an array of other mutations, which I think were probably germline and not particularly relevant. And then for what it's worth, we looked for CH in 6 of the patients and none of them had it. So that's kind of the flavor of who these patients are. So in terms of treatment outcomes, this is looking at instances of these treatments. It's kind of hard to think about this because patients have long treatment courses and they may have gotten 5 treatments over time. So, in terms of all of these 19 patients with their many instances of treatment, if you look at chemotherapy and conventional therapies, there were some responses, but the overwhelming majority subsequently had progression. The way that we sort of captured this, if someone had stable disease and then was changed to another agent, that was sort of counted as a not progression. So this is kind of even underestimating the amount of progression. And in aggregate, the experience was that there was very few instances of definitive treatment with things like chemotherapy or immune suppression. And then MEK inhibition, I'll show some specific cases, but there were certainly responses, but there were 5 instances of progression following MEK inhibition. And because I know that that is of particular interest to this group, I'll just say that 2 of the 5, I think, were because the dose was too low and their dose was increased and they recaptured a response. But there was 3 of the 5 that were, unequivocal, progression on MEK inhibition, even at very, reasonable doses. And then if you think about it on a patient level as opposed to treatment level, again, there were very few patients who were treated definitively with conventional treatments. And then if you take all the patients together, there was 7 who had some kind of progression following MEK or ERK inhibition. And then, because sort of definitive treatment with chemo was so rare, I kind of wanted to look at, well, who are those patients? Is there something special about the ones who were actually cured with chemotherapy? Not really. They were mostly LCH. One person, had chemotherapy for ECD. They had sort of, limited disease or extensive disease. So there wasn't really a pattern to me of who the lucky ones were that were treated, definitively with chemotherapy. This is the swimmer plot of these. And I just want to make one comment, which is that, some of these patients here doing well, green is conventional treatment without any relapse, have actually not been followed for very long. So I think, the other patients would suggest that they may be vulnerable to subsequent relapse down the road. And then sort of the more you go down, you see the mess of sort of the multiple treatments that these patients have gotten, with the red triangle indicating progression. And then what I'm going to highlight now is the 5 patients that have been treated with the ERK inhibitor. So these were essentially uniform single patient protocols with compassionate access to the drug. And it is a first-in-class oral ERK1/2 inhibitor. The recommended phase 2 dose is 600 BID. Because of our sort of collective experience with relative low dosing, I started patients at 25% of that and then sort of titrated up as needed. They got PET CT or CT MRI, more or less every 2 to 4 cycles, and then toxicities were captured per the CTCAE. So we've treated 3 ECD and 2 LCH patients, all with that variant. 4 had either radiologically or clinically progressed despite MEK inhibition, and 1 was entirely naive to systemic therapy. And they were treated with, a variety of different conventional treatments, chemotherapies, and then 4 out of the 5 with MEK inhibition, as I said. So this was data cut a few months ago, but 2 had discontinued and 3 were ongoing for quite some time. 2 of the patients never had to increase their dose from that, quarter of the recommended phase 2 dose. 1 was inched up slightly and another was inched up to 50% of the phase 2 dose, and that was it. 5 were evaluable at least clinically. I'll explain why 1 was only evaluable clinically, and 4 of the 5 had some kind of or complete or partial clinical response. And then of 5 of radiologically evaluable, there was 1 CR, 2 PRs, 1 stable disease, and 1 progressive disease. So just to dig into the details, because I think these matter, this is a patient with ECD who developed this increased fibrothorax here, known pleural disease, despite chemotherapy and MEK inhibition, both trametinib and COBI, was having pleural fluid draining at 100 cc's per day, had chest tubes, and then started the ERK inhibitor, and essentially the catheters were removed within a month. A very, very dramatic interruption of disease pathophysiology. She was unfortunately traveling from across the country to MSK, and at the beginning of the pandemic, this just became completely not feasible, and she came off treatment. However, 2.5 years later, the last time we checked in for her, she was actually still alive and sort of not great, but without chest tubes and functioning, and so was treated with the ERK inhibitor for a short period of time, but is still alive. Another patient with the same mutation, also ECD, had progression in the joints, you can see here, and in xanthelasmas on trametinib, and has this response to the ERK inhibitor and has been treated for sort of between 2 and 3 years now with a sustained response. This patient has basically demon LCH, which has responded to nothing. Blew through chemotherapy, COBE, the ERK inhibitor. Has not responded to anything. Currently is getting clofarabine with, I think, a partial response. So a very, very aggressive case. This patient has LCH, who ulixertinib was her first systemic treatment, and has had this very nice response here. You can see in the brain and in this tissue around the bone. She's had some biopsy-proven recurrence that has kind of proved to be dose dependent. When her drug is increased, it's suppressed, and then when the dose is reduced, it sort of declares itself. So kind of smoldering based on the treatment dose. And then the fifth person has ECD with sort of persistent pituitary disease on MEK inhibition and persistent symptoms. He was changed to the ERK inhibitor with you can see here, a very nice response in the pituitary and a very substantial reduction in his opiate regimen. So the toxicities have been fairly modest. We've seen various kinds of skin adverse events, a few grade 3 events that were all ultimately unrelated. And in our experience, the skin toxicity generally limited, increasing the dose past that 300 twice a day. So overall, this is a meaningful proportion of the patients in aggregate. There's a spectrum of clinical manifestations, but I think overall it represents an aggressive phenotype with very few lasting responses to chemotherapy and even variable response to MEK inhibition. And in 3 of the 4 patients who had been resistant to MEK inhibition, they responded favorably to the ERK inhibitor. So this drug is safe and tolerable in our 5 patients so far. I think it's a very promising monotherapy agent, and we will be pursuing this in a clinical trial, which I just wanted to advertise now. So it will be a phase 2 trial conducted with us, the Mayo Clinic, and UAB, testing the drug in 28 patients with an identified tumor mutation, then an exploratory cohort for patients without an identified mutation. And sort of similar to COBE, patients will be treated for a year, and then with a complete response, we'll have the opportunity to go off treatment into observation. And I think it's a promising avenue of treatment. And that is it. Thank you. I'm happy to take questions.
Just very nice talk. The neurological involvement was no neurodegenerative, correct, in the map?
No neurodegenerative. No. Okay. That neurologic indicator would include like the dura, anything even brain adjacent. Yeah.
Do you think? Do you think it's necessary to demonstrate activation of ERK on tissue to use the drug, or like to have forceful ERK?
For this mutation, you mean, or in general?
Well, you might have a mutation, but sometimes you might have a non-mutated patient for whom you don't have a feasible drug, and maybe you want to try this one. Do you think it's important or it's necessary to have the demonstration of forceful expression on the tissue?
My loose answer is yes, but I always, and I often request that my pathology colleagues do the phospho-ERK stain, although I always sort of humbly recognize that there's all these various tissues that have background p-ERK. So it can be misleading in certain instances, I think, especially maybe in the brain. So I think it can be helpful depending on what they're looking at under the slide. So I think there have been instances where we find no mutation, the p-ERK is positive. I talked to our friends and we believe what that means, but it doesn't always mean what you hope it's going to mean.
Yeah, but so basically you rely on the type of mutation and you assume that it activates ERK. That's the rationale behind the.
I guess so, yeah.
Thank you. I'm trying to understand why the focus always on monotherapy and there is no like trial or research on combined therapy in this disease?
So I think that we all kind of believe that combined treatment is the right next step, but I'm not sure we necessarily know what it should, what it should be. If I can speak for Ken for one moment, Dr. McLean has a lot of experience with, combination of inhibitors and chemotherapy that I think we just have not, as a group, kind of like put our nickel down on what that would look like. But I think it's probably a reasonable thing to do. Yeah. When I've done it, it hasn't worked. I'll just say that. I've channeled my inner Dr. McLean and it hasn't. Yeah.